Is he sold to adults?
Yeah, but it's, we're not sure. The mics are.
Oh, yeah, well, I'm sure. I was there.
Yeah. So, I mean, we really just don't know. Like, the rate was young, I think, yeah, no, that's
But
good.
eventually, probably I will be.
Yeah.
It's better to continue to at least in this, area.
Yeah, I would say like 17 or,
Yeah, she can also continue.
We'll go ahead and get started, I think. Thank you very much for coming today for Grand Rounds. And welcome our Shriners colleagues. We're so grateful to have Dr. Peter Smith here with us today. And our Shriners colleagues, we could just stand up so we can acknowledge you. We really appreciate our Shriners collaboration. Thank you. So I'm going to proceed with our warm welcome. I'd like to welcome each one of you, especially our speaker today's Grand Rounds, Dr. Peter Smith, whose title is Gait Analysis in Children. This is a topic he's very well qualified to discuss, as his positions include attending orthopedic surgeon at Shriners Hospital for Children in Chicago, clinical instructor in the Department of Orthopedic Surgery at the University of Illinois, Chicago, and professor of orthopedic surgery at Rush University Medical College. To begin with a few very brief excerpts from his impressive biography, Dr. Smith received his medical degree from New York University. He then completed his residency in orthopedic surgery at the University of Chicago Medical School and went on to complete a fellowship in pediatric orthopedics at Newton Children's Hospital in Connecticut. Dr. Smith has conducted extensive research and is internationally presented and published his work in such areas as osteogenesis imperfecta, cerebral palsy, clubfoot treatment, gait and motion analysis, arthrogyroposis, and skeletal dysplasia. To briefly turn the spotlight to a position Dr. Smith and I previously mentioned, I'd like to note that Shriners Hospital is affiliated with the U of I health system itself. This partnership is a result of our mutual efforts among leading academic medical centers to reach more children through leveraging our clinical expertise, the clinical expertise of each organization. We are building on the fact that Shriners Hospital is a training site for U of I Health's orthopedic surgery residency, and we are now hoping to establish additional collaboration for pediatric residents who are interested in the care of children with complex medical conditions, and to also establish subspecialty clinics at the Shriners Hospital site. We are delighted to be able to work with Shriners Hospital not only through the educational collaborations, but also to continue and expand our clinical collaborations. The association of Dr. Smith with Shriners, who opened its first hospital in 1922 to give all children access to specialized pediatric care regardless of the ability to pay, is very meaningful to us all. I'm also impressed, for example, of the community service that Dr. Smith has undertaken, which includes the president of the Silver Service Children's Foundation. Because of our mutual interest, that's all our collective interest in this room, in international medical care, another item on the CV that caught my eye was in 2018 was named a Knight by the Colombian Orthopedic Association of South America. I could elaborate further on the values Dr. Smith shares with everyone in this room, everyone in the room, but I know it's a privilege for us to be associated with Shriners Hospital, to share a common sense of mission, to care for all children, to lift all children up to the best prospects they might have in this life. So without further ado, we're looking forward to your talk, Dr. Smith, and thank you for coming today.
Okay, thanks. Well, that was very kind. I've been over at Shriners for 26 years, and I do know all the people at the orthopedic department, and of course the orthopedic residents have always come through and rotated with us about 6 months out of their training. So I'm very, very familiar with this institution, but I have to time actually how long it takes to drive here, because I got an ID, and we're going to start doing some clinics here too in pediatric orthopedics. Takes 26 minutes to get to the Shriners. We're just up north of Oak Park, a little bit on Grand and Oak Park Avenue, right by the M&M factory, if you know that area. You know, this the collab. We of course share the pediatric anesthesiologists from your institution come and do all our anesthesia, and are wonderful. And we have a lot of other collaborations with different departments, hoping to expand that. You know, I wish I would get tips from Zimmer and other manufacturers, but I don't, so I don't buy any stock. Nobody got that reference. The goal of this talk is just to talk informally about gait, something that we all kind of take for granted, but it's really pretty amazing that there is a way that anyone is able to balance the center of mass, which is right in front of their S1 sacral body, over all these segments that move, their hip, knee, and the ankle. And then, of course, your trunk, too. So that's why it takes a year to learn how to do it. You can learn how gait is measured, and look at these common things that parents are always asking us all the time, and you see them, and we see them too. And a lot of things we take for granted, but other things that just maybe how to play a game in the airport if you're bored, looking at people limping and trying to figure out what's wrong with them. It's actually kind of interesting that you can usually figure it out. So the body is top heavy. There's many segments to balance, and it's not mature and smooth till about 4 or 5 years old. That's why we call them toddlers. And but there's all these requirements for it. You have to be stable in stance. You have to be able to have clear your foot when you take a step. You have to have appropriate pre-positioning of the foot and swing when you're coming in for a landing. You want to land right on your heel and not crash on either side of your foot or trip over your toe. And then to make it efficient, you have to actually be able to have an appropriate step length. And you know, this is hard for our kids with spasticity and so forth, where their hamstrings just won't let them take a good step. And then it has to be energy efficient. So that's why a lot of our kids with special needs do pretty well walk, or they get by walking when they're younger, and then when they get to be bigger as adults, it's more efficient for them to use a wheelchair. Now this is also an older thing. I don't know how many people would recognize that. You want the value? So this is from a show that us middle-aged people used to watch called Monty Python's Flying Circus. This is John Cleese, his famous comedic British actor, and so then you have to ask yourself, what is really funny about this? Here he goes. I'm going to stop, but he goes to the Ministry of Silly Walks, where everyone is working on their walk. And then he walks into this office. Those are Eric. There's some other famous actors. And here's this poor guy that wants a grant for his walk, and they say it's not silly enough. He has to work on it anyway. So what is funny about that is that it's completely absurd that someone would walk in a fashion other than how people normally walk, which is this amazingly smooth motion. And we slowed this kid down, but you see how everything works together. The body just sort of flows forward. The center of mass is not bouncing up and down or side to side. And he's got these incredibly smooth motions. And the question is, why is that? Why is everyone able to walk like that? Not everyone hits a baseball the same or throws a ball. So it's not really a learned motor activity so much as a complex integrated reflex that's genetically wired in our brains. That's one way to look at it. And then the other way is to say, we slowed that kid down so you could see all the different segments, but when these kids are running or walking around, the same way we can watch television, your eye only frames at 16 hertz, right? Only 16 frames a second that you can actually take in. And so all kinds of things are going on at the same time. So obviously scientists have been trying for a long time to measure gait, knowing that it's relatively similar. And in fact, all these motion analysis things came in, they had these zoopraxiscopes basically animation, and the wheel would turn around, and the thing would look like it was in motion. And then cameras came along and were able to capture the body in motion. And so there was a famous artist called Muybridge who actually did this to paint for painters to be able to depict the realistic pictures of the body and other things like animals in motion. So from that came an understanding of motion analysis, and that's what I'm going to talk about for a little bit, about how we use motion analysis to evaluate gait, and then normal gait, and then pathologic gait. So in the Berkeley area, there was a famous Dr. Binman who ended up training a lot of other scientists who studied gait and measuring the body motion. Started out with cameras, video, measuring angles off of the film. Now we have these wonderful infrared cameras that frame at upwards of 200 frames a second. Much more complex than we, and methods to measure the foot pressures. And this is an EMG device, which actually is a lot smaller now, is completely wireless. This is our lab. We're very fortunate that we've had some grants, and the Shriners have funded. We're one of about 12 or 15 gait labs around the country at Shriners hospitals, and we are now starting to share our information, so we can do things like do studies on kids with cerebral palsy, different kinds of treatments, looking at the results of treatment, and we have a big interest in the foot and ankle motion, wheelchair propulsion, other things that and to get the engineers involved is just amazing, because engineers can do anything that you if you come up with a problem, they can figure out how to solve it. So this is how we put markers on the body, and then the computer knows where those markers are in space. We have 15 of these cameras all around the room. You can see them, and it captures the body motion within a millimeter or so, and then it makes a model, and then from that it makes a skeletal model, or you can make any kind of avatar you want. And of course, this is how of course we developed it, the orthopedist developed it, but now the Hollywood gets all the credit for all these video games and all this animation. So computer animation really came out of the taking care of kids with cerebral palsy. That's how I see it. Well, it was United Technologies engineers came over to the lab at Newington, and they said, we got these cool infrared cameras, and we can measure this. So. Anyway, so from that comes an understanding of the gait cycle. You can break it down into events, and it's something that is good to understand. And I'm gonna go into this a little bit now to talk about the events of the gait cycle, walking is defined by having at least one foot on the ground at any time. It differentiates it from running, obviously. So you can have both feet on the ground. There's a period of what they call double support. That's 10% at the beginning and the end of in the middle of the cycle. So 20% of the time you have both feet on the ground, and then for each limb. Say for this shaded limb, is going to be on the ground 60% of the time, and so in stance is going to be 60%, and it's going to be swinging 40% of the time. So swing phase is 40%, stance phase is 60%, and it's within several percentage points among all of us in the room that have normal motor function. It's really pretty amazing that how consistent that is. And you can divide up the stance and the swing phase to loading response, middle, terminal stance, a pre-swing, and then initial, middle, and terminal swing phase. You can divide swing up into 3 phases. And you know, to make a study of it, each of those phases of gait has a purpose, has a group of muscles that are firing at a particular time, has a certain angle associated with it, and a certain even force and kinetic function that have all been studied. Okay, let me see if I can do this. All right, so now we're going to talk about what the computer sees, and so this is what our lab sees, and it makes this model, and so it makes a model of the. Can you see that, of the skeleton walking around? I could try to make it bigger, I guess. I don't know if it. Can you see that? So here's the skeleton walking, and you know, we can look at it from any different plane. We can look at it from the top, the bottom. The most interesting is the sagittal plane, and what you can do is kind of slow it down, and so here's a body coming in. Here's a guy coming in, swinging his leg, and he's taking a step. So one way to look at it is you're just falling forward. So you're in single support here. See that? And you look at the swing limb, he's just falling forward and then hitting the ground. So actually, the body center of mass is about it's a couple of centimeters higher here than it is here. So you can look at it as that walking as being like a controlled fall. Boom. And so actually most of the muscles of walking are used eccentrically. It doesn't make a lot of sense, but most of the muscles are lengthening to function during gait. So here you are falling forward, and then you have to absorb this shock. This pink thing is what the force plate sees. It's called an M curve. So you hit the force plate, you get a force there. And if you let me see what I can do here. You look at this here. This is the force plate will calculate the center of force, and actually with the modeling will calculate the ground reaction force and where it passes in relation to your ankle, your knee, and your hip. So you can look at forces too. But when you hit the ground, this is how I like to start about in stance. So you're hitting with your heel if you walk normally, and then you begin a phase called loading response. You got to accept the load here, and let's see. This is what the kinetics are. So if you look at the marker placement, and this is the knee, it'll tell you how much the knee is flexing. So this is a full extension that is 0. And 60 degrees is how much the knee flexes during swing consistently. So you hit the ground. I guess we'll just, let's see which one this is, the blue one or the red one. Okay. So we'll have to look at the blue one here, hitting the ground. Boom. So you hit the ground, and here it is here. See this blue line? So actually, you don't see this very well, but with the naked eye, but if you have a normal functioning quadriceps, you have this thing called a loading response where you accept the load. So your quadriceps is a big shock absorber that absorbs the shock of the initial contact. That's what the function of your quadriceps is for normal walking, just shock absorption. It doesn't participate anyway as an eccentric powering function. So then you get your knee straight, and the reason you do that is so you can balance on the capsule of your knee in the back, and you don't have to use your muscles around your knee to have a quiet stance. So that's an energy efficiency kind of thing. Then as you begin to unweight it, this is where a lot of events happen in walking. And what you're doing is you're pushing up. Actually, what you're doing here, your body center of mass is at its lowest, and you want to get it up higher into single stance so that then you can fall forward. So So really what powers your gait is the inertia of your swing limb. I don't know, and the two muscles that you're going to use to do that are your psoas and your gastroc. And actually people used to debate very ferociously before kinetics about how much push-off there was, but it turns out that 80% of the power of your gait is from your gastroc pushing off with your foot. So you can just imagine this thing, here I'll just do it this way. Look at that back limb, boom. You're pulling it up with your psoas and you're pushing off with your gastroc and you're powering up your center of mass and you're powering yourself forward. You're generating that inertia with that swing limb, and then when you're at the highest point, then you're just falling forward again. So that's all I'll really say about that, except that you can measure all these angles of these things, and of course we all talk about it. The knee flexion, this is the loading response, and it's amazing that in normal gait, everyone pretty much has this pattern. I don't know how I can get back to that, so I'll just close it down. Or maybe I won't. So there's the hip, there's the ankle. We're going to talk about the ankle, but all these things this is in the sagittal plane, looking at it from the side. And then you can do three-dimensional gait analysis, which we do. You generate 6 different graphs, which is what we had before. I'll just put him down there in case I want to use him. All right. Does anyone have any questions about that yet? It's supposed to be informal, right? I hope you can see what you're eating. So the foot is a special interest of mine. I hope I don't talk forever about the foot, but the foot is really complicated. It's because of the and all that, and obviously podiatrists study it for 4 or 5 years. So there's a lot to talk about the foot. But you can this motion analysis, what we're mostly talking about is the foot as a kind of simple lever. This video shows the complexity of the foot and how all these motions are linked together. The plantar flexion, inversion, and adduction, and then eversion, dorsiflexion, and abduction. And that's because of the miraculous subtalar joint, which is really interesting. But here you can divide gait into these intervals, first interval, second interval, third interval, and it's kind of interesting. You hit with your heel, and then this is under control, eccentric control, your anterior tib to let your foot down. Obviously, if you have a disc or something, then you're going to have a slap foot. Then your tibia goes forward against your planted foot under control of the gastric soleus, is lengthening during that. So you're controlling the forward motion of your tibia. And then the third, we talked about, you're pushing off and you're generating that momentum in your swing limb with the push-off power. So it's a really controlled, smooth motion. Requires you to have a stable foot, very good control mechanism, because you're only clearing your foot by about 1 centimeter. And that's why we all trip on little cracks in the sidewalk and things like that. And that's because of efficiency, right? You don't want to take a big step if you don't have to. So here it is broken down, first, second, and third intervals. Again, controlled plantar flexion of the foot to let the foot down on the floor. Anterior tib, L5, nerve root. You can hear your colleagues that have discs walking slap, slap, slap down the hallway, right? This is the controlled motion of the tibia forward from the planted foot, and then this is the push-off power. So we try to teach our residents to talk about the different rockers or intervals, sometimes successfully. Now you can measure all these things, but really you won't understand any of the graphs unless you actually do a physical exam. And this is where, you know, this is what us clinicians like to remind the engineers, that an integral part of gait analysis is how you put those markers on, what you're telling the cameras. You're also doing a complete orthopedic physical exam. And obviously, looking at the gait, you can direct your physical exam, and we'll talk about that a little later. But we need to know leg lengths, we need to know rotations, we need to know what the joint ranges of motions are, and then things, more complicated things like spasticity. More foot terminology, varus, all these things are obviously abnormal, neuromuscular patients. This is a varus. This is very common in a hemiplegic cerebral palsy. Flat feet are not, you guys see, all of us see flat feet. Those are not pathologic flat feet, but some kids with diplegia and other forms have, the valgus becomes fairly severe. And then, so those are just terminology things, what a varus foot and what a valgus foot. All right, so now let's have some fun, maybe. All right, so who wants to shout out why this kid is toe walking? Or what you might notice about her. Is she jerky or is she smooth? She walks pretty smoothly, right? Her center of mass, she's controlling her center of mass pretty well. All that stuff. Do you think she has cerebral palsy? No, I mean, so she just has an untreated idiopathic or habitual toe walker. And the reason you can tell that is because look at how fluid the motion of her knee is. And I mean, obviously you have to do a physical exam, look for spasticity or mild things, but basically you're looking at her in the airport or something, you would say, everything is pretty smooth except she just looks like she's walking in high heels, because she has this contracture of her gastric soleus. Habitual toe walking is an interesting thing. It runs in families, and it's sort of very interesting. But most of the kids have walk at the right age or even early, and they have pretty smooth motion of the knee and the hip. So that's where she is. So you can see the difference, right? Here's a child toe walking, and you know that there's something abnormal with that, right? He's got, his center of mass is bouncing up and down and back and forth. He's got to put his arms out wide to control his bounce so he doesn't fall down. His knees are bent all the time, and not only is he up on his toes, but but really one of the reasons he's up on his toes so much is because his knees and his hips are so bent. So this is a child with a diplegic kind of a cerebral palsy. So you see the difference just walking down the hall, just looking, now that you know that gait is usually a smooth function, you can pick out these differences. Oops. All right, so why is this a pathologic gait, and should you refer this to an orthopedist to lengthen her heel cord? Why is she walking on her toe? Yeah, because her leg is short. So this is a compensation. This is not a pathology. I mean, this kid has to solve her problem, which is that the leg is short, and she wants to walk with her as smoothly as possible. She doesn't want to bounce up and down with her center of gravity, so she wants her center of gravity to be as smooth as possible. So she keeps her knee straight, and she walks with her other knee just a little bit bent, and the major compensation she has is she's up on her toe. All right, so that shows the importance of the physical exam, right? You don't want the computer to spit out that she's an equinus and something to say that you should lengthen her heel cord. That would be a big mistake, because you'd get rid of one of the things that compensates. So when we do this gait analysis game, we teach that you want to sort out the, you want to identify the deviations from the normal gait pattern, which we established there was a normal gait pattern, so that's why we can say we want to normalize things. Then we want to accurately assess it, so we do it with all this three-dimensional and our physical exam. And then we want to separate out what the real problem is and what's a compensation. And we don't want to operate or treat the compensations. We don't want to give that kid a brace either that keeps her foot in a neutral position, because then that'll first of all, she won't wear it, but second of all, you know, that's going to make it less efficient for her to walk. So this is probably review for you, but it's interesting that, you know, orthopedist means straight child, so a lot of effort was made for special shoes and braces to treat this in-towing thing until really Dr. Staley and other people use the science of, if you will, of motion analysis and to try to make it a science of how to measure. How do you measure in-towing, and when is it normal and when is it not? It seems like a relatively simple question, but for a long time, every kid had, you know, special shoes and braces and all kinds of things to make them normal. When in reality, the normal, you know, changes. There's a big range, and it changes through the years. So that if you just look at things like foot progression angle, it's certainly there's a lot more in towers, you know, in the younger years, and these are all normal still, and these are the kids that we see in our clinic, the ones that fall in that range. So the easiest way, and the way we talk to parents about it is you know, we can separate out, and we can use our motion analysis or gait gobbledygook to kind of impress them that we're actually looking at their child, and that we're measuring things, and that we understand about that stuff. So you can talk about the thigh, the shank, and the feet as being the things to look at as the contributions to the in-towing. And so in towing, you know, you measure the foot progression angle. You could tell, you know, in your analysis of this, or your just description of this kid's gait, now that you know, as you could say, his foot progression angle internal about 20 degrees. Here's some more kids with cerebral palsy. These are the kids that W-sit, and you all know about that, and you measure it, and you make this this kind of rotational profile. So you measure the hip rotation. Then I slipped into this. You know, if you see when you're in physical exam, this I do this in every pediatric talk because I see this all the time, that, or not a lot, that someone comes with knee pain and then they have a slipped hip, right? So this is what you teach to your people too. And then what you see is obligate external rotation. So if the hip is stuck in external rotation, then you need to get an x-ray and look for because that's the deformity that the skiffy makes. And I put this in because Dr. Abraham did this, and I don't know if you've seen it, but it's a really good depiction of why the hip externally rotates when there's a skiffy. Doesn't have much to do with gait, but see that? So this is the deformity of the slip capital femoral epiphysis, and when you flex up, you can see the metaphysis is bumping because the head the head is slipped back backwards. I'm going the wrong way. All right, so tibial torsion is the next thing to talk about, and we measure that. You can measure the thigh-foot angle, which is the angle that the foot makes with the thigh. This is convention. All the kids that come to see us, you know, for complaints of in-towing, we have them walk in the hall. We watch them. We say, is this how they walk, to the mother, you know, so they know we watched the kid walk, and then we measure measure all these angles, the internal rotation of this femur, and then we have a rational discussion for a brief, it doesn't take that long, that, you know, the thigh is turns in this much, and the foot, you know, the rotation is coming from and so you know, commonly you see these kids with internal tibial torsion, and you can say we have experience with this, and we've seen that this will change over time, and we don't think that the child needs to have any special shoes or bracing. That's probably doing them a service so they don't keep going around to different places and end up with all kinds of expensive stuff. Now, obviously, there's pathologic causes of in-toeing and out-toeing, and because I'm interested in the foot, you can see that the foot can contribute to that too. So the varus foot goes in and the valgus foot goes out. All right, so if you see this kid walking in the airport, what is your diagnosis? Is it normal gait? No, because her center of mass is moving back and forth from side to side. That's what we call Trendelenburg, is when she leans over the hip that she's standing on, and we'll show why she does that. Now, from your understanding of normal gait, you know that it's not smooth, but obviously she has a pretty good computer upstairs because she's walking, she's balancing on these segments that don't exactly move the way that she wants them to. And then if you understand about what powers your gait, you can see that she's abnormally swaying with her pelvis to kind of throw her pelvis forward. So she's having trouble generating momentum in her swing limb because all she has is her psoas and her adductor really to do that. She doesn't have, well, she probably has a little bit of a loading response, so she does have some quadricep strength, but she's absolutely lacking in any of this push-off here. And she's leaning over her hip because she's missing any function of her gluteus muscles. So if you put that together, you know, the quads are L4, right? The gastroc is S1, L5, and the abductors are L5. So she has a myelomeningocele or some kind of abnormality from the L4 below L4. So she has a myelodysplasia, and you can see how that affects her gait. She doesn't have a normal gait because she can't generate the power, and then she has to sway to the side to balance over her hip. And so when your gluteus muscles are weak, then when you ask someone to stand, the pelvis drops down. That's called the Trendelenburg sign. And then when you want to walk on it, then you throw your upper body over your hip to minimize the moment that the gluteus has to provide. So you're balancing on your hip. So when you're looking at kids that are limping, so that's Trendelenburg, and it signifies a hip problem. Antalgia is when something hurts, so it means that you spend less time in single support on the side that hurts. And here's a combination of the thing that this guy is spending less time on his right leg because he has arthritis and it hurts, and then he's also leaning over it forward and to the side to minimize the moments and forces on it. And so the solution to that is to give him a cane, and you usually give him a cane on the opposite side to where the problem is, right? So then they don't have to lean over so much. Now, we're also in the business, we really like to correct alignment because, you know, there's all these abnormalities of alignment, and that's what orthopedics means, is to straighten things out. There's all different kinds of things that can cause that, and you can calculate that out, And you see that if a kid has a fairly normal control system, they can have all kinds of trouble just from the alignment. But if you straighten them out, everything kind of smooths out. So just a simple procedure to do an osteotomy or a realignment can give you a lot of mileage in smoothing out kids' gait. That's the easiest thing. The harder things are the kids with neurologic problems, where we can't solve the neurologic problem, but we can try to improve their alignment and then go from there. And we can actually model now the length of the muscles and how long or short the muscles are when they're acting. That's called simulation. And we're approaching the stage where we could do forward simulation, where we can try to predict the results of our surgeries. But we're not quite there yet. So anyway, there's lots of concerns that you will see as pediatricians about walking. It's good to have an understanding of normal gait, so you can use it in when you're talking to parents, that you have an understanding. It's not only a fun game to play in airports and stuff like that, but also it can help you in your diagnostic skills. And thanks for your attention.
Thank you, Dr. Smith. That's a really beautiful and just elegant talk. I think just the integration of videos and understanding of just the physics of motion is really amazing. Deconstruct that, like we see in our offices, and even just the deconstructing bits of the mysteries of some of these disorders and really separating out the pathologic from the normal growth patterns. I know some of you want to go to clinic, but I wanted to make sure we left time for questions or reflections.
Yeah.
I went through the time where that tibial torsion used to be treated and then became, not necessarily treated as you pointed out. I was wondering, to what degree is there a percentage of residuals that do not? I mean, when you're talking about reassure and there's a natural course,
Yeah.
is there any residual left where anything has to be done aside from the great change in the numbers?
Yeah, it's not so much the numbers as the functional problems that are people having, and even things like cosmetic, being teased and things. I think I can't remember. It's like on one hand the number of kids that we've done the surgery for those kind of tibial torsion problems. They're just very rare. But if a kid comes and is older, is tripping all the time, or is having some functional problem, then yeah, that'll solve that mechanical problem. But the number of kids, even for anaversion and things, seems to be diminishing now. Maybe that's just not our practice. Maybe that's happening other places, but seems to be less. But we're still seeing quite a number of so-called normal kids whose parents have concerns about these things because they had braces or they had, I think it is a real problem, and in terms of explaining it. Clumsy out-towers, kids that are, and it's something we take seriously because sometimes we pick stuff up, that's not normal, and so we try to spend some time with them because I think that prevents them from bouncing around to all kinds of different other providers that'll give them the answer, that spend more time talking to them and then sell them something. Yes.
For the habitual toe walkers
Yeah.
that otherwise look like they have a smooth gait,
Yeah.
at what age or how much time would you let that go before you should pay?
That's a really good question, and I don't know that it probably varies from clinician to clinician and from parent to parent, but I think that when they go to school is sort of a point where you, to me, first of all, their compliance with wearing a brace is better when they go to school because they just put them on and then they wear the thing at school, and then also it may smooth them out somewhat so they don't get picked on or something like that. But we've certainly seen older kids that have been toe walking for quite a while. My favorite story is that a kid that I was treating with a brace, and then you know, of course, and it was the parents were divorced, and and the parents were fighting over whether the kid needed a brace or not. And the father kept saying, she doesn't need a brace. And I said, well, why don't you come and we'll talk about it. Because I always saw the kid with the mother. And they were, you know. So the dad comes to talk to me in my office. He's looking like this. So I think, you know, it all depends on your view of, you know, how much of a problem it is. But it does become a problem, I think, for balance and stuff like that. That I think, you know, I always offer treatment when they're about the time they go to school, which could be 4, it could be 5, something like that.
So this is in line with the other question, for kids who are sort of neuroatypical and have an odd gait, do you ever do gait analysis with them and things to help them?
Yeah, all the time. I mean, you know, you know, for all our kids with, I don't know exactly what you're saying, neuroatypical.
More like Asperger's spectrum.
Oh, that. Yeah, I mean, we actually have a machine that measures balance that I think is really interesting. I mean, there's a whole field of how kids balance. I guess to answer your question, they have to cooperate enough, and historically, we do the gait analysis when they're old enough to cooperate and when we are thinking about intervening. I mean, there's a lot of kids that don't walk till they're older, and we don't exactly understand, you know, why. Kids with all these other, maybe that's what you're referring to. And I don't know how you can evaluate them to make them walk. You know, a lot of times I tell the parents, you know, they have the strength to do it, but they just don't have the coordination. Does that answer your question, or, I mean?
Kind of. It's one of the things that can sort of mark neurotypical kids might be cross-using is sort of unusual gait.
Yeah. So the kids that are
abnormal arm swing, things like that.
the kids that are clumsy or that have different. Yeah, I don't know that there's a specific. We haven't quantified, which we probably, you know, ataxia or dyspraxia or things like that. There is a gait normal and a gait index, you know, that you can give a kid a score. You know, the computer will do it. You know, look at all these graphs and all the speed and stuff, and give them some kind of normalcy index. So you could probably use that if you were doing a study for things like that. But the kids would have to be able to, you know, have the markers put on, and that you know, it's a pretty complicated thing that takes about, well, it used to take 2 hours. Now it takes about 40 minutes, something like that. Yeah.
Childhood obesity effect?
Well, it does when you're putting the markers on. We, you know, we have to generate a virtual marker for the pelvis because their belly hangs over it. But I haven't really seen a lot about that. I would think you know, walking is still pretty normal for that. Yeah.
I'm wondering about those kids that never crawl and just start to walk, and there are all these old school games that you have to crawl first before you learn to walk, and is there some thoughts in the osteopathic community? I'm just wondering what you think about that.
Yeah, I don't want to be taken wrong by physical therapists because I think they're wonderful, but I don't go much by this patterning business, you know, and there's actually been a long history of patterning in cerebral palsy where parents would go to centers that said they had to do these kind of things to learn how to walk. And I don't think there was much science to it, and there was certainly a lot of time spent on it. You know, even knocking kids back, or even things like having to use you know, if you use not letting kids use walkers or something, because I think, you know, that the brain, even for most of these kids, is pretty smart. The brain will do what it has to do using what it has to And why they miss those steps, I don't really know. Therapists might be able to answer that better. They're pretty smart about looking at the motor development patterns, but I'm not a fan of patterning, and I think a lot of times kids are doing things, that are compensations to like, to tell that kid with Milo that she can't waddle back and forth, I think is counterproductive, because that's the way she can do it. And we have a lot of kids with muscle diseases and other things that walk, and I'm amazed when I measure their strength and stuff that they can do it. And it's because if we were knocked down to that level of strength, we would not be able to walk. But they just have an amazing balance and ability to do it. Yeah.
When will your clinic start, and what type of referrals would you?
Well, we're just pediatric orthopedists like Dr. Abraham, and we're just going to help out. That's all. We're not doing more than that. And then I have two other partners, Dr. Jeff Ackman and Dr. Haluk Altiak, who will, I think they're going to be on Mondays. But yeah. Okay? All right, thanks.